you go. We'll have like the big brother of Mangum. There you go. That's an idea to get some attention for the town.
But will they feed us?
Maybe for competitions, we'll have like games, and only the winners will eat that week.
Yeah, no. No, it will be posted for life. It will be, if you go on YouTube and type in City of Mangum, it'll pull up, and then you can become a subscriber, and any of the meetings will be stored. Personally, I'm grateful that we are being recorded so that all nuances, that all questions that we ask or pose are recorded. And if there's any questions, like sometimes with the city commissioners, or, we can hop on and you can actually forward to that point and then maybe get clarity or what have you. So that's my experience from the last time we did the COVID first round. Second, third.
Hopefully that's not.
That is smart right there.
Burn it up. Ms.
I
Cheryl,
don't think
did you
that-
hear I confirmed
I don't
as
think
well
that
as Ronnie? Okay, there's Cheryl.
Ronnie's here somewhere.
I think he's taking a phone call back there.
I was going to say, hey, I tried to make sure.
Welcome. You're gonna operate. I think if they said we were already live.
But if I turn it off,
Oh, yeah, good call.
Are we still like on this?
No, as soon as they're done here, we'll start.
Your package doesn't have it. But whatever he said has it.
Our packet doesn't have.
What are you looking for?
I would say all of that is right here. Here's that with the links. Not that you use what you forward or come up with the link.
You're exactly on the same email link as we all are. So it should be, it might be your setting in your mail, your mail carrier settings. Because we're all on the same email train. So if he gets it and I get it, it might be a setting. It could be. I'm telling you, it's probably a setting on your end because all the rest of us, we're all tied on the same email and we all have the same. Both of mine didn't, but the one that Dale sent me did. So I hop on the City of Mangum's website and literally go from there because I can read it easier in that format. This was asking. Well, this we didn't get until just now.
This one? That's what you're just talking to when you come in. I'd like to call this meeting to order of the trustees of the Mangum City Hospital Authority. May we have a roll call, please?
Van Sant,
Here.
Lively, here. High school.
Present. Vincent here.
Believe we have a quorum. Before we do the swearing in and seating of the new trustee at this time, if we could have those who are joining us via speakerphone from Teams Hello.
Yes, she, her, with cohesive and performer compliance.
Hi, I'm Andrea Snyder. I'm Cohesive Director of Finance for Renewal. Good evening. My name is Leslie Kerr, and I'm the Director of HR for Cohesive.
Okay, thank you. This time, I believe we have a very special event happening, and our illustrious Mayor of Mangum is here to do a swearing in. Yeah, but we have the Mayor of Mangum is here. Great. I mean, she is a celebrity. There you go. You can take my seat if you like.
I state your name.
I, Ronnie Webb,
Do solemnly swear
do solemnly swear
that I will support, obey, and defend the Constitution of the United States of America
that I will support, obey, and defend the Constitution of the United States of America
and the Constitution of the State of Oklahoma,
and the Constitution of the State of Oklahoma,
and that I will not knowingly receive, directly or indirectly, any money or valuable thing
and that I will not knowingly receive directly or indirectly any money or other valuable things
for the performance or non-performance of any act or duty pertaining to my office,
for the performance or non-performance of any act or duty pertaining to my office,
other than the compensation allowed by law.
other than the compensation allowed by law.
I further swear that I will faithfully discharge
I further swear that I will faithfully discharge
my duties as trustee of the Mangum City Hospital Board to the best of my ability.
my duties as the trustee of the Mangum City Hospital Board to the best of my ability.
Congratulations. Welcome aboard.
Thank you for joining us. Okay, moving on to, do we need a new roll call?
Yes.
Okay. At this time, if we could have a roll call.
Sam,
Here.
high school.
Here.
Lively,
Here.
Benson, here, and Webb.
Here. Okay, looks like we are all present and accounted for.
Did I lose my friend?
He moved over there to be able to properly run the YouTube channel. That will be going viral. Okay. Moving on, we have the consent agenda. I would like to make a motion that we group 3, 4, 5, 6, 7, 8, 9, 10, 11, and 12 together if possible. Does anybody have any?
You don't want the others?
I kind of wanted the clinic report and
They're already on reports. They're on the page, they're on the fourth page, top 18, 19, 20.
cool. Yeah, we can do that. So, group 1 through 15 together. Amend my motion to group 1 through 15, please.
You don't want 16, 17, the whole, right?
You have the new agenda, that is revised.
It just had two things.
Yeah, that's fine.
We just have that, what's it, three to what?
I grouped 3 to 15 together, leaving 16.
So you're moving them out of the consent agenda.
Yeah, we need to hear those, I believe.
Okay, so you're gonna make a motion to approve 1 through 15. Am I correct?
Yeah, that was my motion. Yeah.
3 through 15.
3, sorry, 3.
And not 6.
I figured other people had questions, but if you guys want to include that, I'm cool with that. Okay.
So we're still on 3 to 15. A second.
All in favor?
You want me to call the vote?
Yes.
Van Zandt,
Yes.
Lively,
Yes.
Michael,
Yes.
Vincent,
Yes.
Webb.
Abstain.
Okay. Moving on to item number 16. Does anybody have any questions before we make a motion?
I'd like to speak. I'd like this to be on the record, I'm neither debating, nor am I questioning, nor am I second guessing any of the policies that are listed under item 16. I appreciate the access to the shared file and to be able to have gone in person to read primarily what were the changes of almost a page worth of policies. The statement I'm about to make is simply for if we have an audience that they are aware of, that we, the board, were instructed in February in writing that it is beyond our scope to second guess, to debate, or to inquire about any of these policies. So with that statement in mind, I have a couple of just little comments. The format in which the changes are being put on the shared drive are readable, are good, and I appreciate again the availability earlier today to spend various hours to try and do our due diligence that is being written about in any of the documentation we've been given as to what our duties and responsibilities and fiduciary duties are, not just on state, federal, but also on the level of the CMS-COP for board governance, and I will quote 42 CFR 485.56, conditional participation for a governing body and administration, and it lists that we are supposed to review and approve hospital policies, and because we seem to have been given instructions that we're not, and again I quote, debate, second guess, or what have you. This is not a statement regarding second guessing anything clinical. This is simply the responsibility of I as a trustee towards my community and to our all employees. When we see a list that there are probably changes regarding all these policies in review notice, they only get paid 80, and if you're being terminated, they probably wouldn't get anything. So since we're not
Gonna be on item number
debating,
17.
yet I needed to make that point, considering that it is listed all under item 16. Thank you.
I'd like to make a motion that we approve item number 16 in terms of the upgrades and the changing of some of the manuals.
I'll second.
We could call for a vote, or I'm calling for a vote, please.
Okay. Van Zant,
Yes.
Lively, no. High school,
Abstain.
Vincent,
Yes.
Webb,
Yes.
Okay. Moving on to item number 17, approve the following items. Policies and procedures through June 2020 on 7/14 by quality control, on 7/21 by med staff. So, real quick question would just be, what is the change to the PTO?
It's essentially the information that Board Member Ilka mentioned is correct. The policy is being changed to reduce reimbursable hours for someone that resigns to 80. And if someone is involuntarily terminated, then they would not receive any. And none of us hope that ever happens, but typically employees that aren't performing to a level that is expected, they're given an opportunity to resign, and if they resign, then they would collect the 80 under this policy change.
But yet we're gonna write off 64 hours if I've approved, if hypothetically speaking, if an employee has rolled over 144 hours and still has 144 hours, and the employee puts in her 2-week notice, their notice, they automatically are going to be deducted 64 hours. So as somebody who's worked in HR, I see upon this, the way an employee would react, which is, all right, if that's my newest policy, this is how you do things. If I have 144 hours and I want to turn in my notice, oh no, I'm going to use up 64 hours, they're going to take this away from you. That is the reality that I've lived in practices when policy changes such as this have come along. We, in essence, would agree or would then shorten an employee that has already earned their 144 hours of comp time. This seems to imply that we're wanting to write off 64 hours simply because they give us a termination.
Well, but that's not uncommon.
Okay, but I'm asking is
Yes,
that
ma'am. Yes, ma'am.
That would be
In
correct.
that example, that's correct.
all right? That's all I needed wanted to make sure that the math is 144. If I want to turn in my notice, I better be using 64 hours because otherwise I, the employee, hypothetically gave free labor for 64 hours.
Doesn't that also start to drive a different behavior? If I knew that this is what our policy was going to be, then I could simply go out on FMLA and spend up my time and get my monies so that I don't cheat myself. Doesn't you begin to drive a different behavior out of your people by doing something like that?
I would
It's
imagine.
not an incentive.
I would imagine so.
I mean, I did it when I left my job of 10 years. I dried up. I used 4 weeks of vacation before I put in my 2 weeks over the course of 3 months.
But as a financial, it makes financial sense. I mean, here's the thing. Where I work,
function of the industry, but people that are dealing with this kind of challenge like their time off.
We strongly encourage employees to take PTO.
Oh, I'm sorry.
Self-care,
Yes.
you know, and just to have that time away. So not that they have a bunch of PTO, but take PTO.
If you can, sometimes if it's a small department, things aren't always as easy as it may seem.
I've been here a year and a half, and I've not seen one PTO request even lightly challenged.
Okay.
And we also offer three days of bereavement, and Cohesive is very, very adamant about honoring family. And so any family issues come up, and except for the fact that shouldn't talk about them in public, there are several going on right now, and people are, being treated very, very well, fairly, and with concern towards their challenges with their illnesses and so forth. So.
I'd like to make a motion that we approve item number 17.
Let me ask something. Right behind the PTO, you have the donation form. Can you tell us briefly about that?
Yeah, it basically just codifies the way that you can donate time to a fellow employee, and we do see that happen fairly often.
So it's going to limit them, or you have?
No, it's just a formality. It's they sign off on it. It's documentation.
I have 144 hours and you need some hours, and I may just go somewhere in a month, I'll give you my 67 hours.
Yeah, but there has to be probably guidelines.
Oh, I'm sure it'll be approved since it's been right over. All right, 40 to you, 27 to you. Calendar, not fiscal.
Good questions. Good questions. Thank you.
Make a motion that we approve item number 17. We could call for a vote.
Van Zandt,
Yes.
Lively? Yes. High School?
Yes.
Vincent?
Yes.
Webb?
Yes. Okay. Moving on to remarks. Does anybody in the audience have any remarks not pertaining to any agenda item? Okay, I actually have some remarks that I would like to address to Cohesive and to those joining us via the conference. This will be the first time I was unable to make the last meeting. My apologies. But on Memorial Day weekend, on that Sunday, I was diagnosed with COVID. I thought I, was been spared completely from that. And upon being diagnosed, I reached out to Daniel and said, "Hey, what do I need to do?" And I said, "Hey, I'm struggling breathing." And he said, "Immediately come to the ER." I would just like to say how unbelievable my treatment and care was at that hospital. Nurse Dilbeck, is that right? Was probably the best nurse I've ever had been under care. He was very diligent, very caring, wanted to make sure. Dr. Jeff Brand was amazing. I know, I've said, me and him have had a disagreement in the past, but his care with me and his bedside manner was absolutely amazing. The condition of the facility was amazing as a patient coming in and being in all these different hospitals within the area. I would put our facilities up against anybody. I mean, there was a pretty nice television in there. There was a computer in there that the nurses and the staff could immediately give medicine and do those things. Everything was professional. They were very conscientious of my time and my comfort. These are things I will never forget. Daniel would text me every day for like a week, checking on me to make sure I was okay. I just want to say thank you to all the staff at Maine Regional, but I also want to say thank you to Cohesive for providing this environment. I think we are definitely moving on the right way in patient care is, from at least in my case, in my perspective, was out of this world good. So thank you so much. I just want to stress that enough that I can't say thank you. Anyways, don't want to go over my 2 minutes here. Thank you.
we shoot for an 11-day average daily census. This all goes into play of our, what you're gonna kind of refer to as a balancing act. So, for example, if our average daily census really jumps up, but our expenses stay kind of level, for whatever reason, then that helps us kind of keep an eye on things and, helps analyze and see where we need to maybe adjust, because if our revenues go up and our expenses go the same, we look at what we call Medicare payable, in which we owe back money. And if, say, it goes the opposite way, and our expenses jump up and our, revenue goes down, we generally see receivables from that. So there's, again, many moving parts to that. That's just the top level of it. Cash receipts for the month of June total 1.15 million. This is an increase of about 249,000 from May. Going over to the balance sheet, our operating cash balance as of June 30th is $42,000. If you got a chance to review the balance sheet trend, you'll notice our cash at those point in times during the last 6 months has increased. Part of that, or the main driver of that is our costs have jumped up, due to, our labor demands, COVID, that we touched on in the past, and
provide us? Have we heard anything back?
Yes, actually, we just heard it back today. So what I mentioned previously about the new rate that we anticipated in August, it's reflective of that interim rate request. Currently, they're showing a net receivable over the hospital slightly over 700,000, along with those increases. And we'll actually be doing another interim rate request, about the end, probably submitted at the end of, middle of October.
My team seems to go in and out right now, but I appreciate everything Andrew is doing because I have been there much, especially when I'm sure all that done. And working from home is always the easiest thing, so thank you. But long story short, what she's saying in a nutshell is year to date, we've been underpaid by about over $800,000 approximately. That's what's made our cash shorter than it normally would be at this time. We just received the latest interim settlement number from Medicare. And for example, our swing bed rate is getting ready to increase from 3,000 to roughly 3,718. That's $516 a pop. That doesn't probably sound like a lot, but if you take an average daily census of 10, and you have 30 days, that's 300 times 516 bucks. That's 155,000 a month that we haven't been having all along. So again, it's pretty easy to see. Every year we'll file our cost report. Next year end is 12/31. Their cost report's always filed on May 31st, and we're still actually waiting for that. We have a small receivable in that piece as well. The other good part about this, and just to give you some history, Maine has had several $1 million in ERS debt, and we even had to incur some all the way back to 2016 and 2017, and we have paid most of that off. We're getting ready to bring up in October another $58,000 a month that's going away. So, and we just recently retired another 29,000 in May. So we're not out of the woods yet, but we've made a really big jump and a positive jump in the right direction. So we kind of continue out of the hole for prior years, but we're in a much better position than we ever were. And for those of you who have been board members for a while, just to catch you back up, in September of last year, Medicare completely shut off the facility's cash because of some instances that happened related to 2016. So we were able to get those resolved and moving forward.
Thank you.
That was September. I thought that was like, man, I can't believe we've already gone that far. What is our total debt as of this month?
For ERS, for Medicare, or for everything, Carson?
Everything, including cohesive.
Andrew, do you have that from
I do, total liabilities reflect slightly over 19 million.
Thank you. Does anybody have any other questions? Make a motion that we
You're
approve.
gonna have to give us a moment, we just received some of these to look at, literally, didn't we?
Well, if they're on the sales, but
moment to introduce Jeff Cleveland, our corporate clinical manager, and he's here to make the report this evening.
Hi, good evening. I'm Jeff Cleveland. I'm the Director of Clinic Operations. Thank you for allowing me to come here in person and present this. I know the voices, but now I know the faces, so thank you. I'll keep it short and sweet, going over the June Clinic Operations report. I don't think we met in May. You can see the May numbers at 180. We're trending in the right direction. Very excited about that. All of a sudden, our provider has emergency medical issues that had to require surgery and 2 weeks out. So Cohesive was able to, with the likes of Miss Cindy and some others, secure some other providers coming in and to help take over some of those visits, so we didn't lose everything. But you can see that there's 160, and so that's about 20 off. And in the grand scheme of things, we lost 2 days of treatment. So she was out 10 days. We covered 8 days. So that makes sense right here. The numbers add up. Again, looking down at the clinical encounter or the new patient encounters, 33 new patients. Again, trending up, and meaning that we're bringing new people in. Very excited about that. One of the things, just from transparency, that I think we can do better is that 22% no-show rate. That bothers me. I'm going to write that off partially to summer, but I'm also going to write it off to partially. You hear tell that your physician's not here. I'm just not going to go with on that one. So a little bit higher than I want. I'm going to write this one off a little bit, but we're certainly on top of it, and we'll come back to that next month and see what our no-show rate is.
What is the rate you're looking for patients per hour? Are we still at 2.25 or 2.5? Where are you at? What is it that you're hoping for?
For overall
population-wise,
people
yes.
coming in, our goal at Cohesive is two patients an hour.
Okay. I think
That's 16 a day, that's 2 patients an hour. Give or take, right? That's maybe a little bit more on this one, but a shorter visit
Yes.
on this one. So, and really our transition to the new EMR system is going. We are in the process of data migration at this point. Talk to them all the way from Elk City to Maine. Had that conversation with CPSI and ECW on a joint phone call. So they're working together. Start date, I'm going to tell you, has been moved back to September the 12th. September the 12th. We want to do things right, and if that means putting it off a little bit while data's coming in, we don't want to rush it and get a rush job. Short and simple.
Are we talking about the discussion we had 2 months ago about the software that would enable the provider to see more?
Yeah,
Okay.
yes, ma'am. So we're going from CPSI, which is what the hospital and the clinic have. It's a great hospital function, not so much on the outpatient function. And now we're going in with ECW, eClinical Works, which is not good for the hospital, but better for the outpatient. And we're combining those, we're marrying those up. Any questions that I can answer for you?
I have a question.
Yes, ma'am.
It's, I don't know if it's on the same line of or not. I had an appointment the other day, and it was with a heart doctor that comes in from wherever she comes in from.
Dr. Gibson?
And I just kind of visited with her there, and she said there was a time when the clinic and her staff worked together so that they knew, our clinic knew, who was coming, who was scheduled, and who was going to be there. Why did they move that where they're not working together anymore?
That's a great question, ma'am, and I wish I had a great answer for you. The way that we are built right now is that typically, and this is in Mangum, but this is also in Sealing and our other facilities, correct? That those doctors are different, but, there's room for improvement. There's definitely room for improvement on that, but historically, and I'm speaking from, I have more experience of the ceiling situation than I do here in the Mangum situation, but they beat by their own drum on that. Two different entities.
Right, I get that, I think I understand that. In speaking to the doctor and just in casual conversation with her, I just told her I didn't know that they were there. It was my first time visiting them, and it was not seamless in any way. It was,
Yes, ma'am.
it was very cumbersome, if you may, just because of some other things that had happened. But I asked her, is there a possibility if this works out, if the two marry back up together, because the customer shouldn't be affected by the arguments that goes there, and it was just really.
No, so I'm going to put words in your mouth if I can. It wasn't a good experience.
Right.
Okay, that's unacceptable. All where I come from, what I do for a living, I am a champion of the patient experience, and we will address that. I think it will get better. I do, just for some reasons. But there's something that we need to look closely at. Again, right now, every specialty provider that we have beats by their own drum, correct? They have their, like I said, their own schedules and things. Maybe we should look at somehow having them fax us their schedule before, and so that we have a physical, Miss Smith is coming in at 10 o'clock, so that we know that. Simple things. We just need more communication on that. But you're exactly right, man.
And what I will say about the doctor's office that came in, I've been waiting for this appointment, didn't know when it was going to come. When it finally did come, I got a text that said, hey, you're going to see Dr. So-and-so on this date at this time. Text us back yes if you accept or whatever. I text back yes. The next 2 days, I got another text confirming that I was going to be there, and I showed up on time. It was a really good, whatever it is that they use.
Yes,
it
ma'am.
was
That's
especially
Dr.
since
Gibson,
everybody is
right?
technology.
I'm assuming she's coming
It's
from
Dr. Gibson.
Integris.
Likely does it too.
Yes,
It's a software you can just sign up with, and just how
yeah.
you download and then they just, it's an
It
outside
works really well.
software.
And I've used something like that in my past positions where I just loaded up everybody that was in a meeting with me and texted out their reminders and stuff like that. It's
Yes,
just technology based and smoother.
Yes, ma'am. Understand. And also, she's from Louisiana, so she has a level of class that,
I was gonna say, no, don't knock.
Any other questions I can answer?
Yeah, real quick question. What, to get our clinic running from red to green, how many patients do we need to see in a month on average?
I'm going to tell you 16 today. Can you take out your calculator if you have there? So 16 times 21, 22,
So to an hour.
get to an hour is what our goal is.
Okay.
All right. Any other thing I can do? Thank you for your time.
Thank you.
Moving on to item number 20, the CCO report.
Good evening. My name's Daniel. I'm the Chief Clinical Officer at the hospital. Welcome, Mr. Webb. We appreciate you stepping up and taking this role. Look forward to working with you. What you have before you there is the Chief Clinical Officer report. I'll hit some highlights. I might go out of order, so just bear with me if you will. Before we get going, does anyone have any questions? I'll follow up with some after. Okay. So a few highlights here. There have been 0 hospital-acquired wounds. We're really proud of that. The wound care team continues to ensure overall wound progression. MRMC Infection Prevention proudly reports the continued excellent performance as evidenced by 0 prevalence of hospital-acquired infections, catheter-associated urinary tract infections, also called COTIs, and central line-associated bloodstream infection, CLABSIs. Kind of veering off topic here, I had the opportunity to rub shoulders with some pretty popular hospitals in Oklahoma City not too long ago, and I looked around the room when I received these numbers from our infection control and infection preventionists, and I thought there's not very many other people in this room that can say that, and I was pretty proud of that. So really good job from our infection preventionist. Case management received a report from a patient and a family member. They claim that they have been to many other facilities but have never received the personal, compassionate care that they have been given while at MRMC. things, I will add that the report that you have does not have June numbers on the second pillar there. You'll notice the 4 pillars, one being excellent patient care, excellent client services, preserve rural healthcare, and preserve rural jobs. So under the second pillar there, I do have the June updated numbers for you, and I brought plenty of copies. If you need those, I can submit those, whatever channel we need to do that. Billy, if you could help me with that at the end of the meeting, I'd be glad to provide those numbers. I can say they're trending very similar to what we've seen in past months. But back up to the second bulleted item, actually let's stop at the first one there. The skills fair topic that we had during the month of June, we covered TPN, which is nutrition via the circulatory system away from the gut, if you will, transmission-based precautions, PPE, and G-tube feedings, and AirEvac provided stroke education. If you were to see the report from the month previous, we had a patient with stroke-like symptoms that presented to our hospital, and I'm proud to say that we had that patient in the CT room, the CT completed, blood drawn, and we had everything done from a diagnostic perspective that needed to be done in less than 10 minutes. Super proud of that. So that's our segue into June. What you see there in June is MRMC Emergency Services coordinated with Greer EMS and AirEvac to conduct a mock code stroke. You may have heard about that in town. We had a mock patient at Dollar General that was having some change in cognition and some unilateral weakness. We coordinated with Greer EMS. We did an actual call to 911, and the patient was evaluated. I'm proud to say that they were assessed in the field. Rapid imaging was completed and were transferred to the flight team in 36 minutes. Did y'all hear that? 36 minutes. Super proud of the entire team. Greer County's getting it done when it comes to that kind of thing. What that means is, just to kind of allude to that, you have a golden hour of opportunity. So we still had 24 minutes that we could have used, which is valuable in transferring that patient to a place where they can receive the thrombolytics or the advanced level of care that they may need. Really proud of our team for doing that. Of course, there's some more numbers and data there that can bore you. I won't read that off to you. You guys can read. Any questions, comments, concerns?
Super impressive.
Thanks, sir.
And it was great that you all publicized it. Thank you much.
Thank you, ma'am.
Locals like to see those local things.
Item number 21, CEO report.
Okay, I'll keep this real brief. I'm probably the least important one out there. You can read most of the details in my report. The thing that I'm most proud of, and we've heard 2 examples here tonight, is the patient care continues to be outstanding, and this is thanks to an outstanding staff. I mean, we've had an outstanding staff out there for years. It's just getting better and better. Have a little bit of I struggle with this report a little bit because it's kind of backwards thinking, and I can't keep from talking about what's going on yesterday and today hardly. But we are seeing a little bit of uptick in COVID, and it seems like the severity is less, but we're masking throughout the hospital now, and I just share that from a public perspective, it is more prevalent. We have the critical alert system to complete. That's an item on the agenda here in a minute. So we'll go into that at that point. I might probably use your time better just to open up to questions.
Yeah, some time ago, we talked about, and I don't remember when it was, but we talked about the number of hospital personnel that had gotten their COVID shots and boosts and stuff like that. What percentage are we at now?
I don't think I've got those numbers with me. 100%.
100% of the employees at the hospital are COVID?
Either vaccinated or they have those.
Awesome. That's awesome.
What is the percentile of the exemptions to actual immunization? What's the percent? I know it was small last time we checked. I mean, the percentile of the exemptions were greater than. How many total employees are you looking at?
Well, if we're 100%, that would mean that there shouldn't be.
questions anymore? Thank you.
Moving on to item number 22, discussion possible action in regards to Cardinal Health 340B agreement.
Okay, we've got 4 items here in a row that are all related to the 340B program. Basically, I can tell you the same story on all 4 of them. It's paperwork that's necessary to make this program work. We're all aware that it has a potential, some really good potential. I hate throwing any numbers out there and you'd be disappointed, but we're seeing quite a bit of activity with it already. The first one is PharmaForce is basically the third-party administrator that handles all of this. They're the experts. And it allows, this particular agreement allows for them to coordinate 340B price prescriptions between our hospital, Magnum Drug, and their wholesaler is Cardinal Health. Happens to be the hospital's wholesaler as well, but we just ask for your approval on that.
I did have a question. By reviewing the excellent sheet that you have over on top was just a brief descriptor of it, if it's a renewal or a new. Regarding the contract on that PharmaForce, can you explain the process? When I looked into the details, what it is, like you said, it's that government program having to do with prescription drugs, la-di-da. When I look at the actual contract and I see that, for instance, Pocket Pharmacy is signed up, and then it reads dispensing fees, third party, $15 times 25% of the total reimbursement for brand drugs versus cash at $15 flat fee and generic. Can you translate that? What exactly does that mean? And then at the bottom, there's really small print that reads, quote, as of this day, fees will be incurred at 3 cents per claim from pharmacy. So what does all that mean financially, or is it a rebate program? How do those dollars come? Do we get them? Do we give them? How does it work?
For the name brand drugs, we get the $15 fee plus the 25%, but on the generic, it's just a flat fee, $15.
That we get, that we're paying for, we're entering into these contracts with our local pharmacies.
Correct.
And is that the fee that we're paying them for the scripts you're needing, or?
This whole program, and I'm probably not the best one to explain this, but this is how I understand it. This whole program is because of the government's funding of inexpensive medications. And so what a pharmacy would normally have to pay, let's say $100 for a wholesale, they're going to get it bought for $1 because it qualifies under this program.
Okay.
And it has to qualify under this program. And PharmaForce, they're the experts in this area to manage that process. And so all of this is happening virtually.
Okay.
As the pharmacy is ordering, they've got a certain number of prescriptions that they're going to fill on a monthly basis. We're infusing this 340B program into Mangum, which is going to allow the hospital and the pharmacies to profit more as a result of these reduced costs that this 340B program provides. And it gets really, really complicated beyond that. We just know that it's a good deal for the customers or patients, it's a good deal for the pharmacy, it's a good deal for the hospital, and it takes all of this to make it happen. And beyond that, there are some people that could explain this that help us with this process, but they're not in the meeting right now. They're pharmacists that have a lot of experience with this. This 340B program has been in effect for several years, mostly in larger hospitals. And we're so good question. I'm sorry if that was kind of a shallow answer, but that's.
You can holler at me anytime.
Answer that, okay, and again, thanks for asking any questions.
I could just go and visit Puckett's or other pharmacies and just kind of visit and go, okay, if I was one of those patients and they could just then tell me that this script would, instead of being X dollars, if they are, is it only for patients that come, that are referred from our clinic and from our hospital that get to take and be part of this wonderful program of a drug benefit?
No, as Mr. Dennis was saying here, our providers will write you a script right now. However, if our provider will send you to a cardiologist in, Oklahoma City or in wherever we go, and they write a script for Alquist, that patient still gets that discount, and we still get a cut of that if we can prove that we were the ones who referred them to the specialist.
But does we don't have that context of
That's where Farm Force comes in.
all right.
That's their business to run those and to scrub those notes and scrub those charts to see. We get a report at the end of the month, and within that report is a tab where there's things that we missed or situations that maybe could be but didn't scrub out. And then we have a chance to go back in and justify if we can, if it was appropriate, if it wasn't appropriate. Instance, there was a patient that we missed out the opportunity on that they charged us for, but that patient hadn't been seen since 2014. So that patient probably moved to the city, no longer seeking care from us, but yet it's not punitive, it cost us anything, but yet it was on the report that we needed investigated. So when we did, that was the situation. Thank you.
So, yeah, good.
Sorry, I'm in a European call. Follow-up question. When it is our patient and we refer them and they went somewhere else, do they have to use our pharmacies for the company to know that so it's depending upon using our local pharmacies no matter where the scripts came, because you can trace it by your referrals and therefore then report it and get your whatever percentile. Okay, all right,
But
so it's a trap.
there's a little bit of caveat to that. We can't point them to that.
Right.
So, again, we're not directing you need to go to others. We're going to give you, this thing with the Alquist, and here you go. And there's ways to understand that, we can legally go around saying, you might check out with your local pharmacies to see if you can get a discount. That way, we're not directing you to a facility and getting a kickback or anything that we are working well within the confines of the law. But we cannot recommend the pharmacy.
Typically what they say is which pharmacy do you prefer? And then they say that, and it's either Puckett's or Mangum drug, and it's one or the other.
Yeah.
So the primary thing is that you're able to track that we were the source from whom or why the patient is taking this particular prescription.
Farm Force is able to track it. Yes, ma'am. We don't do the tracking ourselves, right? We don't do that. We're out of it. We just give them a script for Alquist and go. But Farm Force, that third party person, that's why they bill it. That's why they bill it. That's why they get paid.
What do we call that? Shop local. I second that motion.
Call for a vote, please.
And that's for number 22, right?
Yes, ma'am.
Yes, ma'am. Yes.
Lively,
Oh, I'm sorry. Yes.
thank you. High school? Yes. Vincent? Yes. Webb?
Yes.
Moving on to item number 23.
Okay, there are some manufacturers that will only, at this point in time, will only ship to one, pharmacy. And so, these three, Eli Lilly, Novo Nordisk, and AstraZeneca are three of those. So we're asking for approval that you approve their required forms that says that they're only going to ship to one pharmacy.
So you're wanting us to approve that it can only be shipped to one pharmacy?
To the signed up.
We basically have no choice with those three,
Yeah.
with those three manufacturers. They're only going to ship to one pharmacy, and right now, the one that you see there on the explanation is the larger distributor. Brings more revenue to the hospital. Now, I am told by the experts within our organization that this is likely to change, but for now, these big manufacturers are holding to that. It's anybody's best guess, if if the government will force this, but,
What's government money?
so,
I'd like to make a motion that we approve.
I second that motion too.
Call for a vote, please.
Vincent?
Yes.
Lively,
I don't like it, but yes. Nothing
High
to do
school.
about it.
Yes. Vincent? Yes. Webb?
Yes.
Moving on to number 24.
okay, this contract sets out the dispensing fees and sharing revenues between the pharmacy and the hospital. It's basically, a pharma-force contract, giving them the authority to, provide the third-party administratorship between us, Mangum Drug, and, yeah, I was making sure of Mangum Drug. The next one is with Puckett's, they're both the same thing, with Mangum Drug, so we ask for your approval on that.
I'll make that motion to approve 25. 24. And I second.
Call for a vote, please.
Vincent?
Yes.
Lively,
Yes.
High school? Yes. Vincent? Yes. Webb?
Yes.
Moving on to item number 25. Same discussion, possible action regarding Puckett's Discount Pharmacy, Pharma-Force Contract, Pharmacy Configuration Agreement.
That's a lot of words, isn't it?
It is.
But basically, it describes a contract again that, allows for pharma-force to take care of the dispensing of the revenues between the pharmacy and the hospital with, Puckett's.
I make a motion.
I second the motion. Perfect. Lively second.
Lively second. Okay, so Ronnie
Yes, ma'am.
Yes.
and then,
We said at the same time, so vote
okay,
Lively.
so not you. Okay.
Yeah. I want zero
Okay.
responsibility.
Exactly.
And we're gonna call for a vote.
Van Zant?
Yes.
Lively,
Yes.
High school? Yeah. Vincent? Yes. Webb?
Yes.
Moving on to item number 16, discussion.
26. Item 26.
Oh, sorry, yeah, you were correct. Item number 26. The critical alert nurse call system change order.
You guys remember a few months back, we approved the install of the critical alert nurse call system. We're proud to say that that system is doing a great job. During its implementation and prior to actually installation, all we had to go off of was a drawing, a schematic, if you will. And you know, with our infrastructure and the age of our building, once you show up, any improvement things can probably be expected to change some. This will be the change that will complete that project. I would appreciate it if you'd approve that. We have found an excellent benefit to this program in workflows and patient care. It's an outstanding service. We'd
Can
like to
you
complete it.
explain, I did read
Hmm?
all these things, and it said about bundles and what have you. Where will these bundles go and what does that mean?
Okay, the bundles, I think what it's referring to, again, I'm not real techie,
Okay.
but I made a request for one of their pull stations to include the Code Blue system, and I think that's the bundle that I was requesting. There is a little additional cost to that, but I think it'll serve our patients and our staff tremendously, and I think it's absolutely necessary to continue compliance with this system.
All right, thank you.
Yes, ma'am. Any other questions?
I make a motion to approve item 26.
I would like to second that motion. And if we could have a vote?
Van Zant,
Yes.
Lively, yes. Heisel,
Yes.
Vincent,
Yes.
Webb,
Yes. Much obliged. Thank you.
Moving on to number 27, discussion of possible action in the renewal of the Greer County Health Department X-ray Services Agreement.
This is just a renewal of an agreement that we've had longstanding with the Greer County Health Department to provide X-ray services to those patients that can or cannot get the PPD for TB testing.
I'll second that motion.
Thank you.
We could call for a vote.
Van Zant,
Yes.
Lively, yes. Heisel,
Yes.
Vincent,
Yes.
Webb,
Yes.
Moving on to discussion number 28, discussion possible action in regards to the Oklahoma Blood Institute Blood Bank contract.
What you have before you there is a change in our service and what we're getting from the Oklahoma Blood Institute. We currently have a blood bank with quite an inventory of units of blood. As you know, blood is a precious commodity, often used in high trauma areas and things like that. We have consistently been having to send units back to the Blood Institute because they're getting close in days to make sure we don't waste that valuable product. What this will do is this will keep a certain number of inventory in stock for emergency use only. It will relieve us of the need to keep those reagents, which is a huge cost to our facility. We'll keep 2 units of O positive and 2 units of O negative, which are considered, as you know, the universal donor. That will get us the time that we need, even if we do have a trauma, to get the Oklahoma Blood Institute to come out and handle the type and cross match and get us the exact blood that we need. I think it's a huge benefit. It's working well at other portfolio hospitals.
What is the cost? Is it an increase, decrease, whatever?
Oh, overall, it's a huge decrease in cost and expenses.
If we keep the negative and the positive, the O negative and the O positive here, we need something different. What's the time frame that we can get something different here?
They promise to have us the units that we need type and cross match within 4 hours.
In 4 hours?
So we can, and it takes 4 hours. It takes about 4 hours to infuse or transfuse 1 unit of blood if you do it normally. Now, if it's a trauma, we have to push it fast. We can get in there faster. But it's working really well.
I just don't want to be waiting for
I assure you won't. The time that it takes to get from the lab to the ER is how long it'll take you to get blood if you need it.
How often do we do actual transfusions?
Part of the information that you receive is in our utilization, both blood utilization. I would say we on average use about 4 units a month. Some will be more, some will be 0.
That's not a whole lot.
It's not.
But then we're also a little hospital.
Yeah. But we have it if we need it.
When you need it, you need it.
Now, that won't affect outpatient services. Let's say you're with your PCP and they decide you need some blood. You're going to come in that afternoon, we'll have the blood that you need. Simple deal. This is really just for emergency use and trauma type situations.
Yes.
Riley? Yes. High school?
Yes.
Vincent?
Yes.
Webb?
Yes.
Okay, moving on to item number 29, discussion and possible action to an OKCH reimbursement agreement.
Lloyd, I'm not sure you could hear, but, that's the, item number 29.
Yes, sir. Yes, this is a new contract with Oklahoma Complete Health, that will cover our Medicaid, Medicare, and commercial population. Medicare, will be reimbursed at 100% of Medicare. Medicaid will be reimbursed at 100% of Medicaid. And then our commercial, would be at, 150% of Medicare for inpatient, 145% for outpatient. And then, 120% of the our encounter rate for the clinic. So this is a great contract.
Corey, just because, I think at least you review it and think the same. Aren't you, Nancy?
Yes.
We presume that he reads and they're all legal people, so we don't have to ask every time.
Lloyd, I'm confused things, but don't we have Cat's Room pretty well with all of these?
Yep, they go through Pat's Brewer. I look at them myself, and then our corporate team also looks at them. So they go through several phases of review prior to coming to the board.
I make a motion. Does that make sense?
I'll second that motion.
Let's call for a vote.
Vincent?
Yes.
Riley? Yes. High school?
Yes.
Vincent?
Yes.
Webb?
Yes.
Okay, moving on to item number 30, discussion possible action on Stericycle agreement.
Okay, up to this point, we've had a contract with Stericycle for some number of years, picking up dirty linens and hazardous, so forth, and, things that you wouldn't throw in the normal trash. The EPA has recently mandated the hazardous, disposal of pharmaceuticals. And we checked with Green Country, looked for other sources. Stericycle is the only one that we could find, that, is in this part of the world, maybe even in Oklahoma, and it's an additional $215 a month, and again, it's required by the government.
Stericycle is a company, most of the medical professionals and dental, we all do is the same. They're it.
Yeah.
You're right.
Gotta
We
get
only have so many sources.
Good point.
I'll go ahead. If we're good with discussion, I'll make the motion to approve the Stericycle agreement. I'll second.
Ready for a vote when you are.
Vincent?
Yes.
Riley? Yes. High school?
Yes.
Vincent?
Yes.
Webb?
Yes.
Okay, moving on to item number 31, the lease agreement.
Okay, first off, let me say, we, as cohesive hospital employees, we feel very fortunate to have the annex available. It's been a lifesaver for the community to allow for us to function in this pandemic environment. And beyond that, the city council has been very gracious to offer us what appears to me to be an ideal opportunities and plans to utilize the space. And some of the possibilities, I'd stick my neck out and say I think it's a slim possibility that we would move the clinic out there. We've had the provider out there and her nurse and manager and looked it over. It'd be pretty expensive to, and in fact, I think, Jeff, you've seen it. It'd be pretty expensive to develop it into a clinic. But that is something that we'll review more closely. You've heard of the Strong Minds program. Cindy's been heavily involved in that, and we still have hopes to bring that back. And there are some rooms in the back that we could trade out our rental property and develop those for sleeping rooms. That's what they were originally, when it was originally built and provided chemical dependency services. So we don't have any numbers for any of this yet, but we will present all of this to you once you've approved it at a subsequent meeting. And there's even possibility we really need to get that lab inside the hospital. And Daniel, who supervises the lab, is visiting with his lab staff, and the possibility we might want to move central supply out into the annex and move the lab into where central supply is right now. It'd be very, very handy. We're asking that staff to walk out across that parking lot in all kinds of weather. We've got to get the lab staff. And plus, I don't think he would mind. I don't know if he's here or listening, but Mark Chapman, those of you who know him knows he's pretty witty. He said to me, we've got $500,000 in equipment in a $5,000 bill. And at some point in time, that building's kind of a little eyesore, yeah. So anyway, we would ask for your approval on this, and we'll be coming back to you again with different options and plans to utilize it.
Details of this agreement that we're supposed to approve has already, of course, gone through the city commissioner, because otherwise we wouldn't. Do we all know the details? Do y'all care? Well, I read it. I've done. But I just wondered if. So the lease agreement is a well-done thing for $1. The city leases it, and all the liabilities kind of fall onto y'all. Well done, except we can't move walls or what have you, and then we would have to go back to the city commissioner, if I understand the contract. Is that about?
That's correct. Right.
It's
Hospital.
for a 1-year contract, I believe. It's
Right. Year to year, with the expectation that it would be renewable. Corey may have some comments about the way it's structured. As he was involved in the structure of it.
Yeah, it's a year-to-year contract that auto renews at the end of the year. It's a 90-day termination clause.
I'd like to make a motion that we approve said lease agreement.
I'll second that motion.
Ready for a vote, Lima?
Van Zandt,
Yes.
Lively, yes. Issaquah,
Yes.
Vincent,
Yes.
Abstain.
Moving on to item number 32, discussion of possible action to approve the CPSI Evident Interface Agreement.
Anyway, I decided to go ahead and present this myself since I was already standing up here. It might not be the best. This is in Jeff's bailiwick, but basically we need an interface to allow ECW to communicate with CPSI to implement it and going forward. And Jamal and Chad with IT have done a super job negotiating with CPSI. This is something that normally would cost $10,000 to implement, and CPSI is offering it, for what we're existing in payment, and something we've got to have, and no cost, and will facilitate the activity there at the clinic.
So what it does is allow the lab to talk to providers,
Ready for a vote?
Van Zant,
Yes.
Lively. Yes. Heisel,
Yes, please.
Vincent,
Yes.
Webb,
Yes.
Okay, moving on to item number 33. Jeff Phillips.
Jeff Phillips, a PA that fills in for us in the emergency room as well as the clinic, does a super job, lives in the area, and he has been re-credentialed, approved through our medical staff as an allied health professional, and this is, your typical courtesy privileges.
I'd like to make a motion that we approve his credentials.
I'll second that motion.
Ready when you are.
Van Zant,
Yes.
Lively. Yes. Heisel,
Yes.
excuse me, Vincent.
Yes.
And Webb.
Yes.
Do we have any new business that has arisen since posting the agenda that could not have been reasonably foreseen? I will take that as a note, and I'd like to make a motion to adjourn.
Second. Van Zant,
Yes.
Lively. Yes. Heisel. Yes. Vincent.
Yes.